actual sections from our guide on how to achieve this. I think a lot of the vendors, I know we also implement NextGen, has this type of walkthrough where you can go through a reference and say, this is how the information is calculated. We took it a step further and actually said, not only is this how it's calculated in the EHR, but who's doing what at each point in the process. Meeting meaningful use is not easy. The step-by-step guide is 133 pages with screenshots. So this is, you know, a program that requires some work. What we've been seeing with our practices is about a 3-month time to get their numbers up on their dashboards, which I'll show you real quick, to say that I'm meeting meaningful use. So if you're about to implement EHR, the day you go live does not mean you meet meaningful use. So I'm going to show you some tracking systems. For Clinical Works, they have MAC dashboards. They call MAC dashboards, which will show where they are on the dashboard. And these particular measures, the physician who's in all green, numerator and denominator are calculated. But on these measures in red, they still have not met the threshold. So most systems, certified systems, have a way to report this out. This is one vendor. These are the quality measures. Green when they hit the quality measures for that practice, and they've selected these to measure out. And I've also shown you, just so you can have a comparison to another system, this is one of our NextGen clients. Same kind of thing, different format, tobacco use and assessment, tobacco cessation, what their numbers are for 3 other doctors who hid their identities. So MedAllies tracks on our stoplight tracking board our clients and where they are, what program they're going with, how many providers they have in their practice, and if they hit green, red, or yellow on their core menu items, where they are with their attestation. When the practice hits all greens, we've had practices hit all greens, MedAllies helps them walk through the attestation on the CMS website. We've been happy to report that they are getting the money. They're very excited. So that's just a taste of what it's like to be in an EHR and configure a system. The next section is about selecting an EHR. For those of you that have an EHR, you're welcome to stay. Those that have implemented, you're welcome to stay, but you've been through this process before. Any questions about what it looks like in an EHR? Does that help see a visual of how you set these things up for the practices that are in the middle of this? And we'll make the slides available if you contact with us, of course. Yep.
I just have one question regarding the patient education part of the meeting use. If you have patients who come in multiple times for the same thing, we do pediatricians with kids with sore throats and ear infections, must we print one instruction sheet for sore throat every single time they come?
No, you just need to print once.
Once ever in that year?
That they received the patient education.
Just once? For the year or ever? Like when?
I have to let me get back to you on when the time period is. It's in the 133-page guide. Okay, so now we're moving on to practices that are looking to do EHR implementation and what you're going to go through. And I will cover this in super fast speed and then take questions. Okay. Implementing electronic health records, there are areas, and this is my implementation solar system. There are things you're going to go through in this whole process that you need to understand and ask your vendors when you're doing the EHR implementation. There's a project management component, an IT computer component, is how you build the system. This becomes critical. The thing I can stress is when you are building a new EHR system, make sure you have the meaningful use guidelines with you because we want to build those into your system. Data migration is how you get your existing practice management data over to your EHR. That's your billing information, your patient demographics, what insurance they have. Chart abstraction and scanning. How am I going to get my paper chart to electronic? The misconception is that we are going to wake up one day and everything will be electronic. It is typically we see a year process depending on how fast your patients come back to the practice for you to fully become electronic or all your records were your paperless. So a lot of salespeople will be like, oh, you'd be on EHR, everything will be fine, it'll be totally electronic. I just want to dispel that myth. Training and go live is critical. It's just like studying for an exam. The more effort you put up front into training, it will pay off. So we really want to emphasize what the vendor's providing for training. Again, meaningful use, keep those measures next to you while you're doing your system setup and work with your vendor. Modules and interface activations, laboratory interfaces, radiology interfaces, EKG, spirometry. When will those be live and set up in the system? And who's providing my support, and where's the call center? And are they going to be responsive? And I'll make these slides because I have some references in here that you can go to. So for project management, you want to assess your current state workflow. How are you doing things now? NASPRO put out a great guide that you can use to assess your practice and think about how you're going to do that in the future. Also included information technology assessment. When you put computers into a practice, you want to pay attention to where you're placing them. So if you set up, if your nurses work one-on-one with your physicians and they do the initial intake in the exam room, it doesn't do any good to put a desktop in the hallway for the nurse. That's not where they're collecting their information. So you need to understand where that workflow is occurring so you can appropriately place the equipment. If you have, I had a practice that had a triage nurse, perfectly fine. She sat at the desk all day, did triage with the practices. Desktop was fine for her because she was on the phone. We also do a readiness for implementation. We have some practices that actually are not ready for EHR implementation or need some tweaking. This includes making sure you're financially viable when you're going through this, making sure your staff is prepared for this, making sure you have the right hardware and the leadership's ready to do this project. The way I explain it to practices is this is the hardest project you will ever do since medical school. And I am not sales, so I can say that because I do the implementation in the sports side. It is not an easy project, and if you have vendors saying this is a piece of cake, it's not. So we set the expectation with the practice. It is a very difficult thing to achieve, but if you hold tight and hang on, you make it through the process. This is just an example of our assessment. And I included some examples of project plans. So when you're working with your vendor, you want to ask them, what is my project plan? Can I have a copy? Who's managing my project? What resources do you need on my side to assist with the project? This is for a very large implementation that we did. We actually had to create a Microsoft project. This is an example of Excel. So for the physicians in the audience, you can kind of see what to expect when you ask for a project plan. Information technology. Information technology is the foundation that your EHR is going to sit on. If the foundation is cracked, you are going to have problems with EHR. And I see this 100% of the time when practices don't focus on IT, EHR doesn't work, it doesn't go well. So you want to understand what are the hardware requirements for this vendor. You can't use Windows Home Edition, Student Edition to run a clinical information system, electronic health record. What are the network requirements? What do I need to connect in my office, those computers together? How do I protect my practice in terms of firewalls so there's not intrusion from outside sources? And what are the connectivity requirements if you're doing the ASP, cloud, or web-based model? That's all the same term, but you're accessing the information remotely and there's no physical server. What the caution I will give you from doing this for 10 years. EHR is a specialty of IT. In the medical world, it's like a specialist. So you can have a great IT person, they are very knowledgeable, but if they have not experienced EHR, you're going to have trouble. It's just something you learn over time in tweaking routers and understanding that this particular type of computer doesn't work well, like the IBM THINC had this model. You don't want to experience the testing of that while you're going live with an EHR. That can kill an implementation. You also want to make sure a person who has IT background that's been through this understands the future state workflows and why they can't put a printer on the opposite side of the office for prescriptions because the doctor is going to, for the controlled substances, be walking across the office to retrieve that. That comes from experience of doing EHR implementations. Vendors can be certified or preferred, and you want to get recommendations from your vendor. Who would you recommend to do our IT for the EHR project? And these problems, this is probably one of the three main things that can destroy an implementation, because if the doctor cannot function, he or she is the only revenue producer in the practice, and you are losing revenue every minute that practice is down, the physician's down. Scheduling, billing can get by with a system down. A physician cannot get by, especially when all the charts are electronic. So that the cautions are things you want to ask your vendors. System configuration and build. When you're building the system, make sure you involve everybody who touches that process, including medical records, your front office. You don't want to build a system assuming that the appointment schedule should look like this without input from your front office staff. What I caution you is when you have an electronic health record, you don't want to pave your cow-paths, meaning because you had a paper chart before, you don't have to follow that process anymore. Your patient is digital. It frees you up to do all sorts of things. Multiple people can access charts now. So don't limit yourself. If you are creating workarounds in the paper world, you have the opportunity now to do enhancements in an EHR. For example, I have practices who have insurance listings that have been there for 20 years, and it's Empire Plan misspelled, Plan Empire. You don't want to put that into a new system. This is your opportunity to clean up that insurance listing, to clean up things you put into your practice management because they were workarounds. The system couldn't do something. MedLS has recommendations for what you need for the system configuration, and you can accept those or say no. For our practice, we want to do an exception on those and start testing your workflows early. When you think that you are going to collect a copay now in EHR world, when the patient checks in and you're going to scan their license and you're going to scan their insurance card, you want to make sure you test that process. If the patients start coming in EHR world and you're asking them for the copays on check-in, which is best practice, and the patients start saying, I don't want to pay the copays, you've got to be able to quickly change that post-live. You may say, wait a minute, Mary, forget it, we're going to go with the checkout process. And you have to do that quickly. So for a practice, when you're modifying the workflows, you want to make sure you're testing. Walk through a check-in process, walk through a checkout process, walk through a rooming patient. I had a funny story. I was with a pediatric practice where the doctor wasn't used to reading which exam room the patient was in. In EHR, it's electronic. Remember before you put the charts up here and you know which patient's in which room? So I was shadowing the physician and I looked in the EHR, it said the patient was in exam room D. He went into a different exam room. I didn't go because I knew it was the wrong patient. So he walked into the exam room, realized it was the wrong patient, said, oh, I have to go get some paperwork. I'll be right back. So it's something new to physicians. They were used to the charts and the flags before, and now the chart's electronic. This is an example of future state workflows. For those of you who haven't seen diagrams like this, I've given two examples of what they should look like. You can read through them. This is for new patient surgical visit for one of our practices, and this is for a nursing visit. Data migration. So this is your practice management system. What I caution you is to look at your practice management system, determine how clean the data is, how old is the data before you transfer it into the system. There's actually practices I'd recommend don't transfer the data, it's not worth it. The other caution, which I didn't have on here, is your current vendor for practice management will charge you an extraction fee to get that data out of there. Most likely. There's only one system I've seen where they actually don't charge for an extraction, and that's LITEC. For migrations, either from taking it out of your practice management system, your demographic, insurance information, and putting it into an EHR can be disastrous. I've had practices where the IT person has pulled the wrong data file from the practice management system, the old data file. When we put it into the EHR, it didn't look right. There was something wrong. So in Medical Manager, they had Medical Manager, and then the old version of Medical Manager and a backup file for Medical Manager. They pulled the wrong one. So when you're migrating the data to your new system, make sure you double check that data. Check hyphens, check data bursts, check a lot of patients and make sure that they look okay in the new system. I've also had a pediatric practice where they pulled the data And because some of the coding was off in the computer language, there was a pediatric practice and all the patients' date of birth were 1 and 150. So it became a geriatric practice real fast. And the reason we knew this is because all of a sudden Medicare alerts popped up for every patient to get them to sign it. Like, what's going on? And then wait a minute, all the date of births are 1 150. The computer people were able to go and alter the file. It was just a character off that caused that computer to create that. So you really want to get a good sampling of your patients, check them in your new system. Chart abstraction and scanning. This is something vendors typically don't talk to you about until it's too late. Chart abstraction is getting discrete data into the electronic record. And when I say discrete data, I mean typing it in to the system and it is reportable, as opposed to scanning, which is scanning a picture like when you scan documents. It's a picture. The computer just thinks you're one big blob picture. What we recommend to practices is get ready for chart abstraction now. You can't start too early on chart abstraction. So in your paper medical record, you probably have a form that has the problem list, allergies, and or medications on it. You can create a new form to collect that information, but this information needs up to date, and if it's centralized on a form, when you get students or hires that are going to be keying that into the system, they can go much faster. So if I have, and I have, students that can enter 200 patients in a day because all the information is there. If I enter the problem list, the allergies and medications, I can start e-prescribing in the system very easily. It makes the transition much easier for the physicians. You can abstract more data into the EHR pre-live. The problem is it costs more, there's more time, and you have to gather that information, so there's a trade-off. Scanning information into the medical record